Sorry, my bad.
Yeah, I'll start this. Does anyone have any questions? I'm sorry, thought that would have been done. So your background is that you work for the corporation in IT right now.
Right, so I work for the corporate company for IT right now. And well, currently I'm mainly doing the AIT stuff. My boss is allowing me to do a lot of AIT in the building, so.
Okay.
That's about it.
You?
I work at River Valley in Clinton. I'm an advanced med aide and been in nursing for 20 years.
It's nice when I hear med aides or aides that are coming up. I always like to hear that.
Okay.
My name is Cindy Stone, and I work at McCall's Chapel in Ada. I'm the Chief Operating Officer. I've been there 21 years.
And McCall's Chapel has some training programs that we approve. So you probably, if you haven't, somebody at McCall's Chapel has contacted the Nurse Aide Registry. As I said, I've got about 30 years in with the state, and in that time period, before I came on with the state, this is back too far that I want to even think about. I used to be a long-term care administrator back when I was younger, and loved it, but had to quit because of health issues, and then got on with the state with what was called the elder care program, which then got nixed because of budgets. And so in a roundabout way, through things that happened, and that's how life goes, I ended up being the manager for the Nurse Aide Registry. So it was a long circle to kind of get back to long-term care. The Nurse Aide Registry, we are responsible for the certification of med aides. The certified medication aides are the only ones that have some of these guidelines that they have to have. A long-term care aide, a home health aide, residential care, developmentally direct care. They don't have the same guidelines and criteria that are required of certified medication aides. Certified medication aides have the ability, and I think they have a lot more responsibility in the fact that if they give the wrong medication to the wrong person, there are dire consequences from that. So I always like to tell medication aides, I am proud of you for wanting to do that because you have someone's life in your hand. And a lot of that's why I think when they developed the certified medication aide certification, they required the aide to be able to speak and to write and to be able to read English. Okay? And then they have to also currently be certified as either a long-term care aide, a home health care aide, or a DDCA. And they cannot have any abuse findings. That's just a no-brainer. But this is the one that they have to be 18 years of age. A certified nurse aide, which I don't like to use that term because we are about one of the only states that have our aides divided in certifications. So for long-term care aides, they can be 16 years of age. We get that question a lot. One of my better aides was one that came in after school and worked part-time. And she was 16. And she ended up, actually, once she graduated, going to nursing school. So it was a good opportunity. It was wonderful for our facility. They also have to have a high school diploma or a GED. Certified nurse aides don't have to. That's not put on them. They also have to have experience working as a long-term care aide. I'm just going to use long-term care aide a lot for us because we don't need to get into the others so much. And then they also have to have the physical and mental capability to safely give meds. So under the curriculum, a certified medication aide training program is 40 hours. And that's just 1 week of training. And out of that, the combined classroom and supervised training, they have to have a minimum of 16 hours of practical training, or what we call clinical. And in that respect, that's where if this is being taught in like a career tech or a private agency, they will take the aide to one of the facilities that they have an agreement with, and they will let that aide, if the facility agrees, they will let that aide give meds. They have to do a med pass of 20 individuals, or 20 individuals. And then they're ready to go take a test at that point. And they have to take that med pass sheet with them when they go to the testing site to show that, yes, I'm ready to take my test. Oklahoma is probably one of the few states that only has 40 hours of training. There are some states that have 150. There's some that have 60. There's some that have 80. But Oklahoma has 40 hours.
What are the states that do use CMAs?
Just about every state will use the CMA. But one thing, and I just got off before I came up here, because I drove up from home, we're all teleworking. We don't have anyone in our office except one person. Oklahoma does not let anyone come in through what we call reciprocity if they have a certified medication aide. One of the reasons for that is because I think everybody's training is different. Every state is different. Yes, there's a guideline on the curriculum, but some states do 150, some states do 40, so there's no constant in that. So we have never allowed medication aides to come in through reciprocity. Now we will, and we have started letting them do what we call a training exception waiver. So if I came from Kansas and I was a certified medication aide, I would fill out a training exception application, and then we would look at their transcript, what they were taught. Were they taught the same things that we do in Oklahoma? And if it's the same or better, then we will let them sit for a test to become a certified medication aide. But they just can't hop right over state line, not like a long-term care aide can. Okay. Certified medication aides are also different because they are the only aides that we require that they have continuing education. And you're smiling. Would you like to talk about continuing education? It has been, since COVID, I'm going to get off a little bit on this. It has been a nightmare for people to renew their CMA because some of the schools weren't open for a while, or if they were open, if they can't get, this is what happens with some of the schools. If they can't get enough people registered for that class, they'll just drop it. So one of the nice things that's happened, and I hope we get more now that people realize how to use Zoom and WebEx and things that we can actually show seat time, because that's the big deal for regulations. If you say you have 40 hours of training, then you have sat in a seat for 40 hours, or you have been doing practicals for 16. And so not everybody has that capability or wants to be out the money that it's going to cost to get that kind of software program up and running. But right now we have one school that has a CMA CEU update class that is online. And so we have been directing students, aides, to, if they are in dire need and they're trying to hurry up and get certified because they can't get in a class, they've signed up 3 times and they have yet actually had a class. They can go on and do the online class. And that is with Care Providers Oklahoma. If you're going back and you need to tell your facility, there is a way for them to do a CEU. I don't usually plug for anyone in particular, but that's the only online class. I get real leery. Today we had someone come on from a facility because they had read an email that said there was this training program out there that could train their LPNs and RNs, and they were accredited with the state of Oklahoma to be trainers, to be instructors, and they're not. So that's one of the reasons why, in a way, we kind of shied away from online training. But in this last year, we were approached with that, because they also do an online training for long-term care aides too. So they have figured out a way to do that seat time and know that that person's there. So when a certified medication aide has to renew, you're going to have to turn in that certificate for that 8 hours of training. And they can, if they want to, instead of taking a regular, just a certified medication update class, they can take an advanced CMA class. But when they do that, they have to, if they're sending that in with their renewal, the very first time they want us to put it on that they're an advanced CMA, and here I went to nasal gastro, or RG, respiratory gastro. They have a $10 fee for that, for us to add it on. So there is a $10 fee when they renew, and a $10 fee to add the advanced class to it. We've got a lot of questions that's been coming about because of that, because people will send their $10 in, and they said, well, the school told us that they were going to send you our certificate for the advanced. But they don't realize is that we do get notice from the school, but they have to request and pay for that advanced certification. And once they renew, if they just renew their CMA and maybe they have insulin administration or they have respiratory or whatever, after it's put on, every year that they renew is only a $10 fee. They will never have to do another fee on those advances because they're not really certification. They're more like registration. It's kind of a weird deal. I don't know why they just didn't say I'm certified, but I wasn't there when all that was done, so I'm not, I really don't know why they did what they did. So if you have anyone that goes to a CMA CEU update to an advanced class, please be aware that that will not just come on automatically. That there is a renewal application that has to be filled out, and they have to pay that $10 fee for that advance to come on. Also, we've had a few schools that forget this part of it. For anyone to go to a CEU update class, if you say, you know that you've got some aides, some certified medication aides that need to go to class, one thing you need to make sure of before you have them go take this class is that their long-term care certification is current. That is just one of those things that you cannot just go take the class if you're not even currently certified as a long-term care aide or a home health aide or a DDCA. So to be able to renew, they have to be current. And the medication aide is different from the long-term care aide in the fact that their certification is only for 1 year. It's not 2 years. I don't know why they did that. So there's a difference because a lot of times aides will think, well, my long-term care is good for 2 years, and they just think that their CMA is going to be good for that too. It's not. They only have 1 year. If they let it expire past, say their certification expires at the end of November, and they have up to 3 years after that expiration before they have to retrain. But if they go past 1 year, they have to retest. And if they do that, then all their CMA advanced course registrations they had, they disappear. And they have to start all over again. So that's kind of, there's a lot of, it kind of throws the aides off a little bit because they are just 1 year and they get really panicked when they call us. And I think some of the facilities kind of are panicked too if their CMA expires, and they should be, because you can get written up for it if the surveyors come in. But for the aide themselves, they feel such a sense of relief that I've been expired 1 day and I don't have to retake the whole training, because a lot of them feel that way. They got that, I don't know where that comes from because I know they're not taught that in class, but a lot of them think that if I even let it expire 1 day, 2 months, I'm going to have to completely retake the class. They may have to retest and send in a retest application if it's been over a year, but they only retrain after 3. And that's being pretty lenient, really, considering that's the same thing we do for long-term care aides too. The very first year that a certified medication aide becomes trained and certified, when they go to renew that first year, they don't have to have a CEU because they just got trained. So we don't make them have that 8 hours. But after that, every year that a certified medication aide is certified, they have to take that 8-hour course in that year. Okay? What we tell them, because it is so hard to get into a class, because you never know if there's going to be enough people, you can become certified in November and sign up for a CMA CEU update class in December. You don't have to wait until November of the next year, 2 weeks before you're going to expire. That, and then get told that we don't have enough people for the class. And that's what happens to a lot of aides. So as an administrator, I would say one of the best things that you can do, and don't just depend on your HR to do it either, is that you have some kind of tickler system on all of your aides that shows really for everyone that you've got in your building who is licensed or certified, that you know when their certification expires. Okay? Because you can say, well, my HR is going to take care of that. Sometimes things slip. And the buck stops with who? Yeah. Even if you weren't there. It's in the middle of the night and you weren't there. The buck always stops with the administrator. So one of the easiest things to do, and especially now that back in my day, I mean, we did more like tickler systems that were, you know, on a card in a box. Today, it's a lot easier to have a tickler system where it just comes up and reminds you, I've got 3 people that are going to expire this, you know, make it notify you 3 months in advance or 6 months in advance, because an aide can renew 6 months in advance. So if you've got a tickler system that lets you renew, I mean, it's showing this person 6 months before they expire, you can get that taken care of. You can remind the aide. You can print off the renewal application. You can do everything but pay the fee. You know, I mean, sometimes aides need to be handheld through that process, especially if they're brand new. Though we've had some aides that were certified medication aides for years and would argue with us that they didn't have to renew every year. We get those. I'm not saying that you do that. So that first year, they don't have to have the CEU, so they don't have to go to class. So all they've got to do is send in their renewal application and their $10 fee. That's all it is, it's $10. Some states around us do 25 to 50 to even more. Oklahoma, the most in rule and regulation and in law, we can charge anyone for certification is $15. And we haven't even hit that. So it's a $10 fee that they have to sit, and it has to be mailed. I hate to say this, but the health department at this point does not have a software program that will allow them to do online payment. Still, we're still in the dark ages. We've been working on one for, I know, since 2012. And because of changes in legislators, changes in governors, changes, we haven't got one set up yet. We're in the process right now of this company that we're getting a contract with, that pretty soon your aides will be able to do online payment. Yay. Very excited about that. Because what happens is we have these aides that wait like 2 days before the end of the month when they expire, and they're desperate right now to get renewed. And on top of that right now, the health department, as far as the nurse aide registry, is closed to the public. So, and I don't know when that will open back Vital Records is letting people come in, but only by appointment and only one person at a time. And I don't know what's going to happen with that because they just moved the health department to the new building. So, and there's really no place to pay or I don't know how they're on the floor. You can't go up the elevators unless you have a pass. So unless they have us come down and bring someone back up, but right now we don't know how that's going to work. If Vital Records is going to go someplace else. So we're having to tell the aides they've got to mail it in, and they're mailing it into the PO box. So when you go back, please tell the staff that we are closed. Now, we are still working. It's just that you can't come in the building. And we've actually moved to what they're calling the Commons, which is I don't know if they'll continue to call it that. I think they will because there's more than one state agency in that building. We have the Department of Commerce and the Tax Commission are in our building now. And we talked a little bit about retesting. If someone needs to retest, they turn in an application. The CMA will turn in an application and a $15 fee. And it says in rule that they shall retest if certification is expired more than 1 year. The really bad thing about retesting is you only get one shot of passing it. If you don't pass it, you have to go all the way back through training again. So that's another reason to stay current with your certifications, so you don't have to retest. And if they fail, they'll have to retrain, or they'll have to retrain if they've been expired more than 3 years. Okay, I think we've already kind of gone over this part about the age or attending CEU programs with expired certifications. That is something that you just need to make sure of before you send someone off to go take a test. Because if they paid for that test and then they get there and the school tells them, because the testing entity should be, I say should because sometimes things slip, but they should be checking the Nurse Aide Registry to see that they're certified. If they aren't, then that person doesn't get to test that day and has to wait, set up a new test for CEU. So make sure that when they're walking out the door that they are certified. Does anyone have any questions about certified medication aids? I know you don't. So on the advanced trainings, an aide may not attend advanced training if that CMA has expired more than 1 year. Okay? Programs may not accept aides with expired certified medications certifications to the advanced training program. I can't go take an advanced CMA course if my CMA has expired. Okay. And here we have the advanced CMA training will count towards the 8 hours of CEU. To me, it would be a very good idea if you have a CMA to have them have the advanced. Now, some facilities do not allow their CMAs to do those skills. They have their LPN or their RN do it. Especially one of them is insulin administration. We are seeing more and more where facilities don't allow CMAs to do that. Are you allowed? I mean, I don't know what your advances are.
I have both.
Are you allowed to do insulin administration?
Yeah, But they really push, mainly for the workload, they really push for 2 nurses on the floor. And if there's 2 nurses, then the nurses just handle it, unless related.
I think there is for insulin administration, especially if it's a new patient or new resident, and they can be brittle. Then I think a lot of facilities don't want to take the risk of anyone but that RN or LPN doing that. And so we'll see the glucose monitoring. We'll see where they'll allow them to do the finger testing, but not the insulin administration. So most of the time, they combine the classes to where there'll be 8 hours if possible when they do the advanced, because some of these I'm like, I don't know why they go together, but they're doing it to make an 8-hour course sometimes. So your glucose monitoring and your insulin administration, that is a 16-hour class. That's 2 days. And then if you just do the glucose monitoring, that's an 8-hour class. And then they put respiratory, nasogastro is an 8-hour class. Nasogastro can be a 6-hour class. And then if someone just wants someone to be able to do the respiratory therapy, they will just have to go to a 3-hour class. Okay? So on the glucose monitoring and insulin administration, that total program is 12 hours of classroom and 4 hours of practical training, or a 16-hour class. They also, with the insulin administration, they make them do like a little written test too. I don't believe they do that with any of the others. Now, the new online program, they do test after each section. You might do an hour and then you'll have a test and do an hour. But insulin administration is the only one that absolutely requires testing to make sure that they know what they're doing. Do either of you, the facilities that you're in, are they allowing insulin administration by CMAs? I'm wondering if we'll just see that kind of fade out and go away. Woo, I got too fast. So if a facility wanted to, they can send their certified medication aide just for the glucose monitoring, be able to do the finger stick. And the program is a minimum of 6 hours of classroom and a minimum of 2 hours of practical training, or it's just an 8-hour class. With the respiratory nasogastrostomy, it's a combined class of 8 hours, and it has some supervised practical training in there with it also.
It used to be 10 hours.
Really?
I think. I mean, it's been a while since I took it, so.
Well, since I've been here, it may have been 10 hours in the past. They could have changed
I
it.
took it like 6, 7 years ago. And it was 16 hours for the GM and the IA. And then it was 2 days. And then it was 1 10-hour day for the respiratory and
Nasogastro.
yeah.
The one thing about this one is there'll be a skills test and a didactic test, which they only have to make 80% on. The skills, they have to do 100%. And then the respiratory is 2 hours of classroom and 1 hour of supervision. And they also have just an informal exam. They don't have to pass it necessarily, but they will have an informal exam. Some of the questions that we get a lot about certified medication aides is, when they're asking that certified medication aide to work outside the scope of their skill level of what they're supposed to do. And that's one thing I think that is hard for facilities because I don't think they really know what they can and cannot do. That's one of the reasons why I come up and do my spiel, is so you won't get in trouble by having a certified medication aide do something they're not supposed to. Some of the questions we get asked, I'm just kind of like, oh, I'm not an RN, but I know better than that. I mean, I've been in the health, in some form or other, I've worked in every type of facility there is. So one of the things the CMA has to know, and they will call us if they get very leery when they get asked to do something that they weren't taught in class. If they get asked to do something that they weren't taught in class, then they shouldn't be doing it, okay? But they will call because I've had facilities call to say, well, they're certified in an insulin administration, can't they give B12 shots? No. A certified medication aide cannot give any shot unless they've had the IA and it's on in its insulin. That's the only time. They'll also call and ask about topical treatments. And I was trying to think, it was not that long ago, we got asked about if they could do a topical treatment on someone that had a decubitus. And we told them no. Well, can they do cream, prescribed cream on someone to prevent it? Yes. There's a difference there. But some facilities don't even want their aides to be doing that because then you're kind of making a judgment call of when it changes. What you see, what you notice, you know, it can start inside, work its way up, and you don't know it's there until it's erupted and broken down. So the CMA really has to know their stuff. And they have to know about the medications they're giving. They need to know the side effects of those medications they're giving because they're going to be the one that's seeing between them and the long-term care aide. They will see that resident more than anybody else in the facility. Okay? So they have to be able to review the resident's plan of care. Okay? They got to know what medicines that particular resident is on. They have to be able to recognize normal and abnormal conditions for that individual resident. We're not saying that they have to do an assessment, but they have to be able to recognize if something's not right. If I gave you a medication and all of a sudden your face turned beet red and you were acting like your throat was closing or you passed out, you would need to know that that's not a normal condition for this resident, and I need to report that to the nurse. Okay? So CMAs, they don't assess an individual. Neither do long-term care aides. That's the responsibility of that LPN and that RN. But they do have to know what to look for, and that's kind of what they get trained on. But that's also something that needs to be, that training needs to continue once you hire them. Their training should never end because there's new meds. It makes me, my husband had lung cancer He passed away 3 months ago. And he was doing great until they put him on, his cancer started coming back after about 6 months. And they put him on a new medication, new chemo treatment, never been used. And I understood the doctor why he did it. But the thing that when I'm talking about things change, new medications and what to look for and all that, your CMAs need to be updated all the time. One of the things that I had to do on a daily basis after he took that first treatment was I had to call him every day if I saw something different. And every day there was something different. And he died after that one treatment. So that's why I say, you know, every aide, you can't just hire a certified medication aide and say, this is your job and just do it. You should be continually having your RN update your CMAs. They try to do that somewhat in the CEU classes, but the schools don't always know what type of residents you have in your facility, what kinds of medications that you're being asked to give. So there should be kind of a constant training, so to speak, going on for that CMA, because they have someone's life in their hands. That CMA also needs to collect and document data. Oh, this is one that you will see abuse or neglect or misappropriation pop up when they don't document things. Because if you gave this resident their meds and say it was a pain med, and you didn't document it, and then they go to do the count, and that med is not there, guess who's to blame? So that CMA has to document everything, know how to document everything that gets taken. And they have to know that when they walk in the room, that the person that they're addressing, excuse me, I think I'm getting past tell me when I get past my 6 foot. They have to know who they're giving the medication to. I just happened to show up one day for one of our training programs, didn't know I was going to show up to a facility when they were doing clinicals, doing med passes. And so I'm standing back watching the med pass. And the young, she was really young, the aide, I think I tried to stay back so I'd be out of the way, but I could see what was going on. For one thing, I was upset because the instructor was not the one on the med cart with the aide. It was the other CMA. Don't ever, ever, ever let someone come in your facility and give medications as part of their clinicals that instructor is not there with them. A CMA cannot be a preceptor for another CMA. Okay, so that was my first, just like my head's going to explode. The second one was the young girl looked at what she was supposed to give, went into the room, but did not look at who she was giving the med to. And I could see, because they had it really, you know, and they had the pictures on the wall by the names, and they even had it above the bed. And I was like, okay, when do I say something? Is this CMA from the facility going to say something, or how far are we going to go with this? Well, we went as far because I thought surely she's going to look up, see the picture. It's right there on the wall over the bed. She didn't. And so I didn't have to say anything because the CMA for that facility said, wait. you need to, she did a good job, even though she shouldn't have been doing this. You need to look to see who you're giving the medication to. Okay? So there's a lot of things that go on in the giving of meds. Whether it's crushed, how are you going to give it, who you're going to give it, that you give it to the right person, that you document it, because that will get an aide in more trouble than anything if they don't document. I have seen this happen too, where they gave all the meds on that floor and then they document it. It's not the way it's supposed to go. But that's something you should know as administrators. If you see that happening, you need to go talk to your RN. Okay? You don't want to get yourself in a bind or in trouble for something that, again, I'm saying you didn't do it, but the buck stops with you. So the CMA is going to have to report to the licensed nurse or the physician. And when we say physician, that usually happens in assisted livings, you know, because they don't have a nurse on staff like long-term care. They have to know how to contact emergency medical services. They need to receive facility-specific training and orientation from that facility's licensed nurse. They have to demonstrate competency and proficiency to that licensed nurse. And they have to be able to receive delegated tasks from the facility licensed nurse and then perform them. So what I always suggest is when you hire a new aide, a new certified medication aide, before that first day when they come to work, make them do a med pass and watch them. And if they can't do one, don't hire them. Once a year, you need to make sure that they still can do it. There was a situation where this individual had been a CMA for like 30-some, 40, I mean, really a long, long time, and was kind of getting advanced stage. And they finally noticed through the MAR and the count and all that she was giving some wrong meds. And they were kind of surprised because they knew that she'd always been such a good certified medication aide. So it was not, this was kind of unusual. And what they found out when they had her give meds, she was doing a lot of it by memory of the pill because she couldn't see anymore. Her vision had gotten bad and she couldn't see to read what was on there. So, but she would memorize pills. So you really do need to check out and see how proficient your CMA is a year later. And they should be able to be, they should be really, really good after they've worked there a year. If your nurse has done their part and help train some more. Because 40 hours, 1 week of training, and then I'm going to throw you on the floor and you're going to give meds, it's not a whole lot of training. So don't think that when you get a brand new, fresh, certified CMA that they're just, here you go. Here you go. So skills should be reviewed before administrating medication. It's there in rule. You have to do it every year for that annual competency. You have to be able to know that that aide is proficient in giving that med. And that nurse is the one that needs to be doing that. Not another CMA, please. Not another CMA. I kind of Does anybody have any questions right now, or do you have anything you want to say as the CMA, or anyone out there in the ether world? Do you have any questions? Okay. So now we're going to get into the things that a certified medication aide cannot do. And you really need to know these things. And I usually have handouts of all my presentations, and I didn't this time because I telework and I wasn't there, and they don't have our printers hooked up, so we're kind of all in a mess at the health department right now to move. But they cannot apply topical wound care medications that involve decubitus treatment ordered by the attending physician. Okay? They can't act as a preceptor. I got this question yesterday, and the woman was not very nice to me on the phone. No, it was through an email. She wanted her CMA to be a supervisor and go make sure that all of her other CMAs knew what they were supposed to be doing. And she argued with me when I told her you cannot do that, and she made me go to rule and bind it because she didn't take my word for it either. But they cannot be a preceptor, nor can they be the one that judges whether or not an aide is, a CMA is doing their job properly or not. That has to be the nurse. They cannot administer PRN medication without a documented assessment unless authorization is obtained from a licensed nurse on duty or on call, and unless fully documented by the certified medication aide. This is more of a problem that assisted living centers have, because they're not lucky enough to have that RN there on the floor. So this really kind of hits with them. They can't perform blood glucose testing unless they've taken the class and they've been certified. Nor can they administer insulin unless they've completed the class. They also, even if they've completed the class and have insulin administration training, they cannot work with a newly diagnosed diabetic. Okay? And especially, it requires insulin administration based on blood glucose levels and does not have a clear physician order for variable or sliding scale, or is an unstable diabetic. But as I'm hearing, I don't think there's very many facilities that this is going to be a problem, because they're not allowing the certified medication aide to even do that. Administer medications or nutrition via nasogastric or gastrostomy tubes, or administer oral metered dose inhalers or nebulizers unless the CMA has completed that approved advanced training and has been found competent. Okay, so once they take the advanced training, what should happen when they get back to the facility before they do it? That nurse needs to take them and watch them do it and actually know that they were found proficient in being able to do that skill. And they can't take or note physician orders either. You would think that would be a no-brainer, but sometimes it's not. We get busy and sometimes people just do things that they really shouldn't. Grounds for denial, suspension, withdrawal, and non-renewal of certification. If that aide intentionally provides false or misleading information to a training program or a facility, like when they're getting hired or when they start doing their training, if we can stop them from being able to be trained. You also have the right then to fire them if you want to, if they lied about something when you were hiring them. Failing to administer medications as ordered by a healthcare professional with resulting actual harm that is either life-threatening or has a negative outcome for the resident. Failing to consistently document that medication, altering the records to cover themselves, altering or falsifying certified nurse aid or certified medication aid identification cards, or diverting drugs. That's a no-brainer. I mean, we see, or I see, because I see what happens. I get the reports on the abuse registry. We had a young gentleman who, from what the facility said, was a really good aide, a certified medication aid, but he had a really bad headache. And they had one of those big jars of Tylenol. It was on the medication card for some reason. But anyway, he took one. And a family member saw him, turned him in. It wouldn't have mattered anyway. What did he do? Even bulk supply. A certified medication aid, when he could have just gone up to the nurse's station because they had a bottle up there, but he was busy. He was in a hurry. I don't know what happened, you know. Maybe they got behind that morning because somebody was throwing a fit, didn't want to take their meds, but he had a headache. And because he took one Tylenol off the med card, he will never give meds again. And sometimes I don't know if medication aids are aids just in general really truly understand the do's and don'ts and why. And therefore they get themselves in trouble. So, and then of course, we see the diverting of drugs. You see that. Where pills just come up missing or they dropped them in the floor. And sometimes I truly believe this happens. They drop them in the floor and throw them in the trash and they don't document it. And all of a sudden, med count is not correct. It can happen. I know you're going, no, nobody would do that. But those are some of the stories we hear when you go to a hearing. Practicing nursing or medicine except as authorized in the law and by regulation. They can't just do anything they want to. That even means if we had a situation which we couldn't do anything about because it happened in a hospital. Hospitals love to hire long-term care aides and certified medication aides. And I don't understand this, but anyway, they knew that this long-term care aide had been a certified medication aide. This was a hospital here in the city. And so the nurse, the RN, was really busy, and I think there was a problem with this resident. And she said she had the pills in her hand. She gave them to the aide. I'm not going to call them med aid because they're not med aides in hospitals. But she gave them to the aide and said, "Can you give these for me? They're counted out. Here, give it to them." Instead of the aide going, "I'm not going to do that. I can't do that." She did. The lady died. So they have to remember their place and what they can and cannot do. It is part of the facility's responsibility and the administrator to make sure that their aides know what they can and cannot do. You need to know that yourself. I mean, you really, really do. So you don't get in a bind and have something happen. They also can't represent themselves as a CMA without a current certification. So if they're not currently certified, they can't call themselves a certified medication aide. That gets taken away. You gonna say?
You can't write a number 4, they can't do it.
No. Once that certification expires, you're just anybody off the street. They cannot administer medications in a setting other than those authorized by law. So the only places they can administer medication is a long-term care facility, assisted living, a residential care facility, a developmentally direct care facility, home health. It's a weird deal. I'll talk about home health and CMAs in a minute. And they can also give meds in jails or correctional facilities. Yeah, you can do that if you want to. You're good? All right. So those, if they do anything like that, the department can deny, suspend, withdraw, or not renew. But really, if they do any of those, what usually happens is you will do an incident report, a 718. It gets sent to long-term care, and then long-term care will come out and they will review and they will make a determination if they need to investigate some more, and if they feel like it really did something really got diverted or bad happened, they will send it to our legal department. Our legal department will look at it. They'll put a pending on it, which flashes pink. Okay, so when I look at them and I pull them up, I know that there's a pending on them, our database. And I think the way that is supposed to work too, and I think Barry was here and probably talked to you guys, the National Background Check Program. I think it shows up on that database, but it doesn't show up if you look them up in hours. It won't show. It'll show if there is abuse, but it won't show a pending. And since we have most of the cases that would usually come through on abuse, you would see misappropriation, and that's that diversion of drug. Does anyone have any questions? Okay, I've also seen, it doesn't happen a lot, but I have also seen our administrative judge be a little bit lenient if the circumstances warranted it, and they would suspend their certification instead of completely keeping them from ever being able to come back and be a CMA again. The first time that happened, I was pleased because the circumstances were such that even though the Aide did do what they did, it was just one of those things where you just went, it was the RN.
Oh, okay.
So sometimes when they do that, they'll suspend the license, but it can't be less than 6 months. Okay? And we can deny withdrawal or non-renewal, but not less than 1 year. So those things can happen if they do that. So once again, I want to reinforce that every year your CMAs, their skills have to be reviewed. Someone needs to take them around, watch them pass meds, see that they know what they're doing. And it has to be done by a licensed nurse. Okay? So the facility has some responsibility when it comes to their CMAs. If you use a CMA, the facility shall have policies and procedures. I bet y'all guys got bombarded with this through training. But you have to have procedures that address ensuring that training, skill validation, task assignment procedures are approved and implemented. License supervision and oversight and availability is there. That is a biggie, the availability. And staff intervention during an emergency. Do you know where your manual is for your facility in case of emergencies? I'm just curious because
I would assume by the nurse's station.
Administrator.
Yeah, we have our administrator.
it's gonna be in the administrator's office usually. Now, it's a good idea to have a copy of it, I would say, at the nurse's station, because what if the administrator's gone and they've locked their door? Which I did. The one thing that you can never, ever, ever have enough of as an administrator is policy and procedures. Think of anything that possibly could happen, the worst thing in the world, even the chicken falling out of the sky, and have a policy and procedure for it. So you don't have to worry that if you're not there, there isn't some place for your staff to go and everybody knows where it's at. That will cover that situation. And that's where a lot of times when we see abuse, neglect, or misappropriation, or we see facilities getting written up for deficiencies, a lot of times it's going to be on those not having a policy and procedure. Maybe they have it and it's written in a book, but it was never taught. Or the book was there, but no one knew where it was. So it doesn't do you any good to have all these beautiful policy and procedures if the staff don't know where they're at and they haven't been trained on it. Okay? And that goes clear down to housekeeping, maintenance. You should have, everyone in your building should have known policies and procedures for emergencies and what happens in that time period, because it can get really crazy. Procedures for responding when a resident has a change in condition, has side effects, or does not respond to the medication regimen as identified in the care plan. That needs to be there for that certified medication aid. Also for the nurses. And that documentation has to be maintained. I don't think it's ever changed. That whole thing that just stuck in my head when I went to administrator school back a lot of years ago, probably 30. Oh my God. If it's not documented, it wasn't done. I don't care if you got witnesses. Sometimes, if it's not documented, it's not done. So documentation has to be changed. Reporting errors to the licensed nurse and the physician. This is really important that your staff feel comfortable and feel a part of a team enough that if they make a mistake, that they will come and tell you, that it can be documented, that they're not afraid of the wrath of what's going to happen if a mistake is made, so therefore they try to hide it. That can be, you have to think about that, because that can become a culture in your facility. A fear that if I make a mistake, I'm just going to immediately be fired. Because a lot of times, we don't want anyone to make a mistake. We want them to be trained well enough that they will never, ever, ever make a mistake. But if a mistake does happen, you want them to immediately notify you so you can take care of And you need to report those violations of those in chapter 677 to the state health department. Okay? So if your CMA has advanced training, you also have to have procedures written up on how that's handled in your facility and what happens if something doesn't go right. And standards for monitoring and assessment by an RN and an MD, including how often does that have to be monitored and assessed. Distinguishing between type 1 and type 2 diabetes and stable and unstable. Procedures for blood sugar testing, collecting data, charting, graphing, and recording data. Standards for reporting to the licensed nurse or physician on a timely basis, which definitely includes medication errors. And contacting emergency medical services. You need to have procedures on training, orientation, and delegation from the facility. So everybody knows their role in your facility. Because some of the things we hear was, well, I wasn't told I was supposed to be responsible for that. That can come from a nurse, you know, and especially for AIDS. Drawing up insulin. I don't think most of y'all that's going to be anything, but minimum qualifications for CMAs and facility screening of applicants to include assurance that each CMA has the physical and mental capability to safely perform the duty. You'll find that out as soon as you take them around and let them give meds, if you think that they're going to be able to do it or not. Following physician orders, including sliding scale orders, that's on insulin, and safety and infection control. That is still in the top 10 for deficiencies. And right now with COVID, it really is an issue. I mean, we have someone in long-term care that's all she does is sit and look at the policies for COVID, infection control. So the one thing you can never do wrong is have your policies and a lot of policies and procedures that will cover anything that you can think of. But the next step of that is then make sure that all your staff are trained on them. You may have to do quite a few in-services on that. And you cannot just give an in-service this year and next year think that everybody's going to remember it, because by that time you may have all new employees. So a lot of this is a continual training because you lose aides quickly. We're seeing even in COVID where we're allowing facilities to train the aides themselves. It's an abbreviated training. I don't know how long this is going to last. I don't know when this will go away, but for now, that's what facilities can do if they want to. They can give them 16 hours of the required training before they can touch a resident. They can give them 10 hours of Alzheimer's training, and they can have them do the skills performance checklist. Okay? And even in doing that, we are seeing aides that get trained at one facility, and that might take a week. We'd like to see it maybe take a week. But they're already gone to another facility. So your staff will move a lot. Aides move a lot. So you cannot just you're going to have to continually do training on your policies and procedures. It's just that way. I think I timed it where we're supposed to take a break right now. I'm going to give you guys like a 15-minute break, and then we'll come back, and then we'll go over your long-term care aides and the rules and regs on.
This conference will now be recorded.
Okay, we're going to start on the second half, which is going to be in regards to your long-term care nurses. I mean, not nurses, your aides. Your CMAs are really important, as we've already talked about. And they have the capability of really hurting people. But then you get to your people who are going to be providing the hands-on, direct care, the ones that are going to be the nurturers, the ones that are going to have to put up with the families and try to do everything they can for that aide. They will develop if they're good aides, they'll develop very strong attachments to their residents. So long-term care aides and developmentally direct care aides and home health care aides all have a minimum of 75 hours of training. As I think it's California, their long-term, they call them a certified nurse aide, they have 150 hours. And they have about that, and most of that is clinical training, which I find really cool. But we have a minimum of 75 hours. There's an initial 16 hours of classroom, which they have to have that training before they can actually touch a resident. And then they have to have 16 hours of supervised practical training. 10 hours that's required for the Alzheimer's training. And they have to have approved clinical sites. So 75 hours training, 46 hours of those are required on those topics I just told you. So that only leaves 29 hours left to do any other training, like labs. There's a difference when I say clinical training, 16 hours of clinical training, that usually happens at the very end of their class, and they go to a facility and they actually will work on the floor and they're usually paired with one of the facility aides. With the instructor, please know this. The instructor, when they come to your facility for clinicals and bring their students, they are not to go to the nurse's station and sit. They are not to go outside. They are not to drop their students off. They are to be with that student, or 10 to 12 students, how many they're taking. If you see someone drop them off and that instructor doesn't stay with them, please feel free to call the Nurse Aide Registry and let us know, because that is a definite no-no, okay? So if you've got that going on in your facility, know that it's not right. And you can tell them, if you bring students to our facility and we allow you, here's your word, allow you to do clinicals, then you have to stay with them. Because a lot of things that they sign off on as a skill that they've been found proficient in, it may happen in your facility. So they have to see it. So here is the 16 hours that are required before they can touch a resident. They've got to have training on communication and interpersonal skills, infection control, big, safety and emergency procedures, including the Heimlich, promoting a resident's independence and respecting a resident's right. After they've had that 16 hours, then they could go in and touch a resident, but not before. So we ask usually the training programs to do this at the very beginning, the first 2 days. CNAs have a scope of responsibility and a specific role in resident care. And that scope of practice refers to the task within their certification and the skill set that they were taught. it's very critical for you to know that a CNA may not perform services that they have not been trained on and have not been found proficient in. So it's another thing when you hire a new CNA and they start up. If they're brand new and they're coming out of a 75-hour class, they're green. Okay? They do know. They've just been taught, so they'll remember that because they've just been tested on it. But there may be things that your facility will need to help make them better with their training. It's not a good idea when you hire someone fresh out of training to just throw them out on the floor. You want to, and we have it on our website, it's a skills performance checklist, and I usually bring it, and I'm sorry I wasn't where I could print off everything I usually do. But you can use that skills checklist anytime. Just go on there, print it off, and if you have someone new come in, have your RN take them around and see if they actually know how to do those skills or not. Okay? And if you see that there's a weakness in a certain area, that gives you an indication that, yeah, this aide may be really good, but we need to bump up. We may need to help this aide out a little bit. Maybe he knows how to do it, but he doesn't feel comfortable. So just know that. And if an aide tells you that they have not been trained to do it, you cannot train them. It has to be done because if they haven't been trained, then it was a skill that they shouldn't have been doing. Okay? And we get those kind of phone calls a lot from facilities who are wanting aides to do things that they cannot do. Also know that if you're wanting to hire somebody and you're waiting for them after they've retested, it can take up to 30 days for them to show up on the registry from the test site. But if you have an aide that's not listed there within 30 days, call us because something's gone wrong. Maybe there was a glitch, there was something. One of the things that we are no longer doing anymore, and I think most people know this, but we still get a few phone calls from aides that say their facility wants them. We no longer print or mail out initial or renewal cards. The reason we quit doing that partly was due to the budget, but the other thing was because it says in rule and regulation in chapter 677, that's the Bible of aides, okay, that the facility is required to verify that the certification status is there and they do not have a finding of abuse, misappropriation, or neglect. Okay? So you can print that out from the website. Now I have to tell you, and I'm sorry I'm going to have to tell you this. Our website was not user-friendly to start with. So we got told about a month ago, in the middle of all this moving and everything else, that we were going to get new web pages and it was going to be better. I can't find anything. So when you pull up the Nurse Aide Registry, it not only has our stuff on the left-hand side, but it has other divisions listed. So you've got to just keep going down the list and you'll eventually find what you need. But that's how it is right now. I'm sure that there's going to be a lot of cleanup done after we get moved and everything kind of calms down. But you can still verify a nurse aide on the Nurse Aide Registry. You just have to scroll down quite a ways, almost to the bottom of the page. They put everything that we had in the middle of the page. So you just keep scrolling. It's awful, but, so you can verify and print out their verification. Here's all of the information that you need. I feel really bad because I never even thought about this when I did this, but they just changed the Nurse Aide Registry phone number to a new 426 number. But you can still reach us on the 405-271-4085 because it's forwarded at this time. And we'll be notifying and sending out notification of our new phone number. Because we're not with the OU Health Science Center anymore for our phones. We used to all be 271 numbers. Now we're 426. We now don't have phones. We have phones on our laptop. It's called soft phones. And so we are in the process of learning how to use all that. So we have a new number, but you can still use this one if you need us. Until we get that where we can put it up on our new website. Okay, recertification for long-term care aides. If they are the long-term care only, they can use the 717, but now we also have come up with a form that's called, it's an 840, that's long-term care only. That form can be faxed or emailed to us. It doesn't have to be mailed. The only renewals that have to be mailed are the ones that have fees attached to them. So this is my time to tell you, there is no reason ever, ever, ever for a long-term care aide to not be certified timely. Because if you've got a tickler system built and you know when they're going to expire, you know that you can go in at any time. You can fill out all the paperwork for them, have them sign it, and email it or fax it to us. It's just that easy. There's no money involved. So, and we usually get to our emails and faxes in 2 to 3 days. We're getting so many right now, we're just bombarded. So, we don't send out, we have stopped sending out during this time period where we were in the governor's executive order, where all renewals they've been suspended. That stopped as of October the 23rd, and you now have 60 days to renew. So they can still work. They're good, but they just need to, and I will say this about most of the long-term care aides, even the CMAs to a great extent, they've been really good about keeping their renewals up, even though they didn't have to. They just went ahead and sent it in because it's that easy. So it's really easy for facilities now to just take care of that. Have your HR do it. I mean, why not? So applications can be found and printed from our website under certification renewal. Used to, before we moved, and before COVID, a person could walk in and be renewed same day. I don't know if we're going to go back to that because I don't know where we move to is going to have that capability. So if you have someone who has a CMA, make sure they can renew it 6 months in advance. Have them after they renew to immediately take a CMA course. Not to wait to the last minute. And then there's always the online too. So, and it takes, for some reason, if we have individuals in Tulsa, for some reason, it takes about 4 days for mail to get from Tulsa to us. That they take longer than someone from Altus. I don't know why, but it just works that way. So your long-term care aides can renew 6 months in advance with the new form. I've got the email is nar@health.ok.gov, or they can fax it. Now, right now, you can fax it to 405-271-1130. You may want to call later, and we may have a new fax number. But right now, they're letting us do that. Aides will stay on the registry 30 days past expiration. And there is not a grace period, really, to let an aide work. We work renewals the same day we receive them from the mailroom or finance, but I can tell you right now, we're about a week behind on renewals. And that happened because of the weather. And then half my staff didn't have electricity. So I was one of the lucky ones because I lived in Pauls Valley. We didn't get ice. But so we got behind. We're behind right now about 7 days. A facility may not be decided if they can prove application was mailed before the expiration date. And a lot of times we try to, if you have them come in and you know that it's been mailed and you know that we're behind, we've had surveyors call us and ask us, are you guys behind? You know, they're saying whatever, and we'll go, yeah. And it's probably here, but, and they won't do anything. But try not to wait till the last minute to do it. If you just do it early enough, you don't have to worry about it. Some of the problems that we have when we go to renew aides is the application won't be filled out completely. Long-term care aides have to work at least 8 hours in the 2 years of their certification. Okay, that's, if they don't, they have to retest. So they can give us a pay stub, a W-2 form, or the facility can fill out, there's a section on the renewal application that says where they've worked, when they started, if they're still presently working there, or when you fired them. That can be filled out also. So if someone comes to you requesting that be done by your HR office, please tell them to do it. We have some facilities that refuse to do that for the aides, and it makes it rough on them. You may not like them, you may be mad at them, but they're trying to get another job, and hopefully they've learned from their mistake. They also will not fill out their affidavit of lawful presence. This is a law of Oklahoma, where everyone has to prove that you're a U.S. citizen. Okay? So the very first renewal, you have to fill out a form that says either you're a U.S. citizen or you're a qualified alien. If you're a U.S. citizen, you won't ever have to send it to us again. If you say you're a qualified alien, then we have to run you through what is called SAVE. It's with the federal government. It's their database for qualified aliens. And so we have to have the front and the back of their card, and sometimes those are counterfeit. And so if we find that they're counterfeit, we won't renew them. So if you ever have someone that you know they've sent their paperwork in and their expiration date is still there, you may want to call us, because there may be a reason why. Also, make sure that they don't make a mistake and put down they're a U.S. citizen when they're actually a qualified alien, because if they do, it's an automatic kick out. You're out of the United States. So we used to work with Homeland Security a lot more than we do now. They used to call us on a weekly basis. haven't heard from them in a long time, so I don't really know what's going on with them, but we are still doing that. We have to check them. Also, if an aide has an Oklahoma tax hold, we can't renew them. And just because someone has a tax hold does not mean that they didn't pay their taxes. It can be that they moved to another state, or they moved here from another state. It could be that they didn't file taxes because they didn't make enough to file taxes. But if you've been filing and then you quit, and then you start back up, you may get a tax hold put on you. It's just kind of a weird thing. So, and it takes a while to get those taken off. So, if they have a tax hold, it will not let us, our database just will not let us renew. Or if the aide didn't sign their recertification application. And we also now, because people can email or fax to us, a lot of times they just email us their work proof, but no application. So we have to have that. Because if their address is changed, we have to update the database. If there's an Oklahoma tax hold, or if there is any problems, we don't just drop it and not do something. We send either the aide a letter telling them of the problem. If they've given us their email address, we will email them what the problem is. And sometimes if we have to, we will phone them and tell them what we need so they can email it back to us. If there is an Oklahoma tax hold, though, they're going to have to go to the Oklahoma Tax Commission. We cannot do anything. We're not supposed to know any of that. So once we get a tax release from the tax commission, then we can process it. And at this time, we're approximately 7 to 9 days behind. And it'll vary. We were where we were daily. I mean, we got them done same day, but the weather just has really done a number. So when the recertification application is actually processed and the aide is certified, as soon as we hit the renew button, it shows up in the database. So as soon as we hit renew, you can look them up and you will see it. You don't have to wait till the next day for it to show up. It shows up on our database immediately. Because I've had aides that said, well, I'm just going to sit here and watch it until you do it. And I was like, good, I want you to see how fast this goes. So you don't have to wait anymore. So you're to verify whether or not an aide is certified by checking in our website. And if you need it for your files, you can print out the verification or you can call us if you have any problems with that. There's also a retest application, and it's the 841, and it's not for long-term care because it has a $15 fee on it, and that is usually for CMAs or a DDCA, home health aid. The only aid that actually doesn't have to pay for renewal is long-term care aid. They don't, and that's the one that we have the most of. Right now, I think we have about 59,000 certified long-term care aides and about 129 that are just hanging out there and could be certified if they wanted to. So the reason that they would have to retest is because they didn't work the 8 hours for pay. They think if they volunteer, that's going to work. It has to be paid time while certified. Or if they've been expired over 2 years, but less than 3, they have to retest, and they can only retest one time. And if they fail, they have to go back to school, which is really, I would have so much test anxiety over the one time only. It scared me to death. So there really, to me, for long-term care aides, there really isn't a reason for that to happen. Back in November of 2015, the Long-Term Care Advisory Board was pretty upset with us because the pending abuse that we had on our aides could be on there forever. And the reason for that was, and the aides have figured it out, was that if I don't pick up my certified mail, then they can't have a hearing because I wasn't notified. So long-term care wanted us to address it. They didn't feel like that just left these pendings out there forever. And their facilities, and I understand why, are leery of hiring anyone that has pending on them. So what we did, they came up with a law that if an aide moves, they have 10 days in which to give us their new address. I don't think they know this still real well.
Really?
No, because I mean, some are really good, but we still have a lot that we don't know that they've moved until 2 years later. Or they'll complain about they didn't get something I didn't receive a problem letter, and it's like, you've already moved again since we sent it. So what this did is it permitted the department, the legal department, to send out a certified letter, which was telling them they had a hearing. And if they don't pick it up and it comes back to us and it says couldn't deliver or not there anymore, whatever, they now take them on to administrative hearing and they'll place abuse on them without them being there. So we get phone calls from aides that said, I didn't know anything about this. I don't know how you can place this on me when I never went to a hearing. And then we have to tell them this. So that's one thing you can help us with, is telling your staff that they need to notify within 10 days if there is a change of address. We also have to know if they've changed their name, if they've gotten a divorce or they've remarried, because the way people are looked up now by name, if their name is not the same, it causes a problem if it's been changed. And so we used to, they could just tell us or send us a driver's license or whatever. Now we have to have the actual document that changed the name. We have to have a copy of it. Notice of change address or telephone number shall be made within 10 days. But notice shall not be accepted over the phone. They can email us their new address if they want to and their new phone number, but they can't just call us up and we go, yeah, we can take care of it. I wish we could, but that's just something we're not allowed to do. That's just talking more about if it comes back unclaimed, moved, refused. Legal just goes ahead and does the hearing, which is sad, I think, because I think everybody should, the aides should not be afraid to go to those hearings. They shouldn't. And I have seen facilities come with the aides because they were fighting for those aides. And we've got a really good administrative judge who takes into account what was going on, what was happening, taking into account the resident. But no one likes to see someone lose their ability to be an aide. But if it's necessary, then it is necessary. Some of the stuff is awful. So a long-term care aide's performance appraisal should be done every 12 months, and they are supposed to have 2 hours of in-service specific to performance review. And so that's some of the licensure requirements. A training and competency examination program shall not be offered by or in a facility within the previous 2 years if they've had substandard quality of care, and request copies of the that's just what we tell them, to request copies of the CMS 2567 or access them at the clinical site. So just be aware that if you have a facility that got hit with substandard quality of care, you are not to have any training programs coming in doing clinicals in your facility. And it's for 2 years. And a lot of times what we see is that facilities will be hit with a deficiency, and long-term care surveyors come back and that deficiency still exists. It wasn't cleaned up, or they find something brand new. You don't want that to happen. And then so they come back a third time and they still find it, or they find something new again. And that's when the penalties start rolling. And if there's been substandard quality of care, you need to notify whatever training program is coming into your facility. Don't hide it. Just make them aware that they cannot come in. One thing that we can do, but now we have to go a different route than we used to. Used to, if there was not, say, like, you're the only facility in your area. Some, like in 3 or 4 counties around you, you're it. If you have cleaned up your deficiency and it is no longer there, you can request us to waive that and be allowed to have clinicals in your facility. It's just that it's changed the way, we've had to change the way that can be done. Depending on the deficiency, we have to contact CMS and let them know that, and CMS gives that approval. But I just wanted you to know it's not a complete, you have to wait 2 years. If there is nothing, if a school has nothing within a 1 hour trip back and forth, the school can get with the facility and ask the facility to please request from us a waiver. And then we have to get with CMS on that. Other enforcement that could prevent training in your facility is an RN staffing waiver, civil money penalty of $10,483 or more, a license that's been revoked, Medicaid certification terminated. The department may withdraw approval to train as a result of all these of even care deficiencies. Do any of you have training programs in your facilities? You do? Okay, so you kind of know. Do you mind telling the name of your facility?
McCall's Chapel School.
That's right. We talked about it. See, that's how quickly I can forget.
Well, we own a few, but I know the one we were doing it at was our Jones location, Oak Hills.
So those are the things that you got to keep in mind as an administrator, that you could lose that capability of having students come into your facility if you're hit with any of those for 2 years. So, and it does happen. And we do give waivers. I have, not since the new way is they ask it to be done, but we have given quite a few waivers, especially in Southwest Oklahoma, where there just isn't anything else around. Sometimes there might be one facility and the next one's like an hour, hour and a half away. How many of you know about temporary emergency waivers? It's hard to talk about this right now because what I'm going to tell you is and talk about today is the way it is without COVID. We have changed this with COVID. But a temporary emergency nurse aide waiver allows you to use an uncertified individual as a nurse aide for 4 months or less. An entity must have a temporary waiver approved. So you send in an application to the Nurse Aide Registry for that temporary emergency waiver. The initial fee is $100. It's good for 6 months. And then you renew it and it's $75. That allows you to have individuals that are going to school in an approved training program to come in and work in your facility, but only, this is the catch, but only on the skills that they have been found proficient on. So if you have someone coming, they need to be bringing you pretty regularly their skills performance checklist so you can see, well, what did you learn today that I can put you on the floor doing? Okay? If you, and especially if you've got a training program in your facility, you want to have this. Because then you can work them on the floor while they're being trained. And that's why we ask that those 16 hours of required training, remember it was communication, infection control, resident rights and responsibility, but those need to be done that first 2 days of training so you can get them on the floor. And then you can start doing your lab. And in the lab, you can start teaching them the real basic things that they can go out on the floor and start working. What we've done with COVID is we've taken this temporary emergency nurse waiver and we've kind of done away with it. And we've given everybody one. It's like, you all have one. You don't have to turn in for one. And that allows you to do that abbreviated training. And then when the training's over, then you have to send that training documentation to us with the training exception waiver, and we'll allow that individual that you trained to test. And they get 3 tries. And they get 120 days from the time that we receive the application, approve it, send the letter. They get 120 days to go test. Okay? So it's giving the facilities the ability to not have to wait. Because at the time that we did that, the career techs and the private sites were shut down. They were not having the students in their classroom. And plus the fact some of them have opened back up again, but they had to have the PPE to be able to do clinicals, or well, they weren't even doing clinicals because they couldn't come into your facility, but even to do the lab, because I couldn't get 6 feet from you and act like I was doing anything for you. So that is the biggest reason that we went with the waiver for the COVID. Now, how long that's going to last, I have no idea. In fact, that's gone to legal right now, and we're asking them the question because that wasn't like the governor approved it, but it was not really like an executive order as much as it was a waiver of rules. And CMS approved it. CMS said, this is what you guys are going to have to do for your facility. We've already gone over that. You can only use them in-house for 4 months. At this point right now with COVID, you can use them as long as this waiver is in place. I would send them to go test if you're doing that. If any of you are using the COVID waiver, I wouldn't wait till the end to go have them test. I wouldn't also train them 1 week and have them test the next, because there's no way with abbreviated training are they going to be able to pass the test. They might pass the skills, but the written, I'm not sure about. So we talked about that they had to be from a department-approved training program and the 4 months. And then after they go test, if they pass, then they'll be placed on the Nurse Aide Registry. You cannot use someone who is not on the registry. If they have tested, you have to wait till they show up. I mean, they'll come back with a coaching report that tells you that they passed, but you can't use them until they're actually on the registry. So sometimes that takes, as I said, we have up to 30 days. What did I do? So any nursing facility, specialized facility, continuum of care, assisted living, adult daycare, or residential care that employs an individual who is in nurse aide training as provided in this section shall ensure that the trainee shall complete the required training and competency program and as approved in rules prior to any direct contact. That's the 16 hours. Not perform any service for which the trainee has not trained and been found proficient in by the instructor. So, and they have to be supervised at all times by no less than a licensed practical nurse. So you cannot just put them on the floor and let them go, okay? Or have another aide be a preceptor, because we kind of see that sometimes too. So one of the reasons this statement is up here, it says the required training must be done by a department-approved training program. When we first took over the emergency training waivers, we had some facilities that thought they could do the training. That's what that meant. And it isn't. It's just allowing you to use someone who is going to an approved training program. So if you're a facility that doesn't have a training program and you want to hire someone, they need to be going to school at some career tech or private training for you to be able to use them on your floor. So facilities which have an approved nurse aide training program, they can use their RN or LPN to instruct their nurse aide trainees in the facility in accordance with the rules and regulations listed above. And if, which I usually have people that don't have training programs in their facilities, if you ever have a question about your training, or if you wanted to do a training program and you didn't have one, you would contact Jason Noreen, who is our surveyor for the training programs, because the Nurse Aide Registry, besides being responsible for the certification of all nurse aides, we are also responsible for the curriculum and for the training programs. And we have to go out, he goes out and surveys the training programs to make sure that they're doing what they're supposed to. So I imagine have you ever met with Jason?
I haven't.
You haven't? Well, right now, he's not allowed to go anywhere. I mean, CMS is saying that the surveys for training programs is not that big a deal to with COVID going on. So we're just holding off until that happens. So I really got through quickly today because I didn't ask a lot of questions. I'm not used to that with the class being this small. It's kind of different. Do any of you have any questions about nurse aides or what they can and cannot do or anything that has to do with them? Well, I will say that your nurse aides are really important, just as your CMAs are, just as housekeeping, just as your food. Take good care of them. And if you take good care of them, you don't have to worry because they'll take care of you. We hear from a lot of aides that feel like they are not appreciated or respected, or they're being made to do something that they weren't trained to do. So, you know, they're what's going to make or break you. And so take good care of them. And I wish you all the best. I know you guys are tired. It's been a long training program and you're ready to go home. So Z, I am through, got through early on this.